it is such an exciting topic, because for palliative care to develop as a discipline, we need to breed leaders who can push it and who can support palliative care in leadership positions and make decisions that support palliative care. So today we are very honored to have Dr. Esther Munyoro, who is going to take us through this session. Before I introduce Dr. Munyoro and make general remarks, I introduce myself. My name is Makula Inatieno. I am the Executive Director of Kenya Hospices and Palliative Care Association. So equally, I'm going to benefit from this session as an upcoming leader. And before we start this session, I was going through some quotes which people talk about who a leader is and what a leader is supposed to do. And I'd like to share just one or two which caught my eye. So there's one by Max Dipper, who mentioned that there are three roles of a leader. The first one is to define reality. And this reality is where a leader turns a vision into a reality. And then the last one is to say thank you to the people who make it happen. So in between, the role of a leader is a servant. And then there was another one by Tony Blair, who said something like leadership is saying no, because it's very easy to say yes. And the one which I think applies to today's session is by someone called Wendell Wiki, who said that education is the mother of leadership. So when you are educated and we learn more about leadership, that could also support and help us to gain our leadership skills. But that's something for us to discuss, and it's an opinion, and you might all have opinions about leadership. And we know we've had a contact with leaders. We have political leaders and all the various kinds of leaders, and yeah, we've had experience with them. But today we are going to learn about leadership in palliative care. So I'd like to welcome all of you, and please type in the chat your name, if that is possible, and where you're coming from, so that we're able to welcome you, and even the other partners are able to interact and know that you are part of this session. And also in the Zoom down there are tabs. There's a question and answer section. So please, even as Dr. Munyoro will be talking, if you have any question, you can type it in there. And if you have any comment that you'd like to discuss with other participants, you can put it in the chat. I'd like to have the pleasure to welcome Dr. Esther Munyoro, who is a neuroanesthetist and a pain and palliative care specialist. Dr. Munyoro holds a master's degree in palliative care from Dundee University, and she recently retired. But until her retirement, like in November 2019, she was the head of the pain and palliative care unit at Kehpca National Hospital. And it was the first unit within the public care systems in Kenya, which she was the founder in 2007. So Dr. Munyoro has also been involved in various projects that aim to improve the quality of life of those undergoing treatment for cancer. So the start of our wound and stoma and incontinence service at KNH, and the education of various cadres of healthcare workers, coordination of initiatives in cancer care in partnership with the American Cancer Society, that is the pain-free hospital initiative, the patient navigation program, as well as the ongoing construction of the Kenyatta Hope Hostel for cancer patients and caregivers, are all part of the portfolio that Dr. Munyoro has been able to lead and even support successfully even before her retirement. She has also been a board member in various international and local organizations that advocate for improvement and support of patients with life-threatening illnesses. So from the bio, you can see that she has an experience at service delivery at international and national levels, board level, as well as administration level. So we are really delighted to invite you, Dr. Munyoro, to share with us as current and future leaders in palliative care. What are some of the key things that we should take forward as we even support the development of palliative care in Kenya and beyond? So thank you and welcome, Dr. Munyoro, and welcome our participants.
Okay, thank you very much. I am going to start sharing now. You can all see the screen. You can see the screen?
Yes.
And you can hear me well?
Yes.
Okay, fine. Thank you very much for your introduction. I am this talk about effective leadership in palliative care. So this is the way it will go. I'll first discuss and define leadership, and then I'll tell you my journey through starting the palliative care unit in KNH, and I'll give my final thoughts as to the way forward in palliative care. So let us start by trying to decide what is leadership. And as it says here, leadership involves influencing the attitudes, the beliefs, the behaviors, and the feelings of others. So that one, as a leader, you require traits that extend beyond management. So in leadership, you must be more than a manager. You must be able to have the art of motivating a group of people to act towards a common goal. So you decide, you set goals, and you try and influence people's feelings, their attitudes, and their behavior so that all of you can move towards this common goal. And maybe we need to go back a bit and decide, what do we believe palliative care to be? Because sometimes I find there's a bit of misunderstanding about palliative care. And palliative care is actually patient-centered care that improves patients' quality of life by dealing with their health-related suffering. So when patients have serious illnesses, when patients have chronic illnesses, they will get health-related suffering. And palliative care will actually deal with this health-related suffering. So as a leader, you want to influence, and who are you trying to influence? You're trying to influence the patients with what you tell them. You're trying to influence families as you tell them what the way forward needs to be with the patients. You're trying to influence the other healthcare colleagues. We're trying to influence the healthcare system. We are trying to influence the insurance. We are trying to influence the community. So in leadership, we must have ideas, and these ideas can be original or they can be borrowed. So you can, in the leadership in palliative care, you can use your own ideas or you can borrow ideas. But it must be more than managers, because managers may not be described by others as inspiring. But if you're in leadership, people working under you must say that you inspired them. So management is doing things right, while leadership is doing the right thing. And management is very important, but you first have to get your leadership right. Now, the other definition of leadership, which I think applies a little bit better to palliative care, is that it's a process of social influence that maximizes the efforts of others towards achieving a goal. We've already decided what our goal is. It is to improve quality of life. So we must be able to influence all the others, because palliative care is so wide. As a palliative care giver, you actually cannot do it alone. But if you can influence everybody to practice patient-centered care and to care about patients' quality of life, then this definition then works very well, because then everybody is maximizing their efforts towards achieving that one goal, which we all try to achieve in palliative care. So we should try and integrate palliative care into the healthcare system so that regardless of who it is in our hospitals, they will be thinking about the patient's quality of life. So if you compare leaders and managers, leaders focus on people. They articulate a vision and create a future. As a leader, you must empower your colleagues. You must trust, you must develop, and also you must develop them. Leaders create change and they serve others, and they use influence. They also use conflict, and actually conflict works very well sometimes when you are trying to push some ideas forward. And leaders must also be very must act decisively. Managers focus on things. They execute plans and they improve the present. So they are in controls, directions, and coordinating. And once the leader has created the change that needs to happen, then the manager will manage the change. So managers use authority while the leader is using influence, and managers avoid conflict and they act responsibly. So there's a very big difference between leaders and managers. And some people make good leaders, others make very good managers. So in leadership, you must be able to offer guidance. You must have solutions. And while you're trying to get that solution, those solutions, it's where sometimes there's conflict because of people's beliefs and the way they want things done. You must have a vision as to the end result that you're trying to create. You must have teamwork because you will not be able to do it alone. You must get the team to work in a certain direction. You must have strategy, be very good in communication so that you can actually get to the goal of where you're trying to go. So I have a question here. When you listen to all that, do you think leaders are born or are leaders made? So we are going to have a quiz and we're going to have you answer. Do you think leaders are born or are leaders made? Howard, do you have the quiz? So choose one. So are leaders born? Yes. Are leaders born? No. So if they are made, the answer will be no. If they are born, the answer will be yes. So are people born as leaders? Then you will say yes. Are leaders made? Then you will say no. So we'll give you 1 minute. So how do you let me know when we are done?
So we have 52 participants have participated in the poll. So maybe we can have a bit more. Can give it 30 seconds and then we continue.
Thank you.
Can give it maybe 10 more seconds. If you haven't participated, please do. Okay. So I think we have 66% of people have participated so far. So maybe we can end it at that. Okay. So I will end the poll.
So are you able to tell us, what do people believe? Leaders?
Yeah, I've shared.
Okay. So this means 64% of people say leaders are born. Is that what you understand?
Yes.
Okay, and 36% say that leaders are made. Okay. Sadly, I have to tell the 64% that they have failed the exam. Leaders are not born, leaders are made, according to my research. So research shows that 1/3 of your leadership qualities are in you, but actually the other 2/3 you have to work to acquire. So actually leaders are made, because leadership requires a complex set of skills that you actually need to learn. Sorry. And you actually learn them through self-development plan. So if you want to be a good leader, you actually have to go out of your way and have a self-development plan, because leadership is a set of personal competencies that you have to get, and that will be knowledge, skills, and abilities. And I'm sure you're wondering which they are. You must learn conflict, how to deal with conflict. You must learn good communication. You must learn about people's different personalities, so that you know how to get your team to work together. So actually, for you to be a good leader, the self-development plan is very important. So leaders are made, they are not born. So I just wanted to show you some of the leadership courses that I went through. When I started palliative care, I was an anesthetist, and I was actually told by the hospital that to be allowed to do palliative care, I needed to go back to school. So I actually went and did a diploma and a master's in palliative care. And after that, I then did the leadership courses. And I'll just point out the ones that, and the different things they brought into me. So I learned about quality of life by doing the palliative care, and how to empathize with patients, and how to really listen to them and help them articulate exactly what they wanted. And then I did a leadership course in San Diego, where I think the thing I took out most was personality types and teams, and how, depending on the different personalities you have on your team, how to get them to work together. So this is something I really encourage each one of us to do. Get your personality type mapped out, so that you also understand how you deal with everyday situations, how you internalize things. And it also helps you deal with other people. Once you get to understand why you think a certain personality is difficult, you will find out they are actually not difficult personalities. It is the way that they look at things. I also learned how to make an elevator speech, so that you get your idea, because you're not going to influence people. You're not going to create the right relationships. When you're given that few seconds to just tell people exactly what you're talking about, you then need to have an elevator speech. And then we needed to educate people in palliative care. Again, you need to be taught how to teach. A lot of us assume that it's very easy to teach, but you actually do need to learn. And we did a foundation course, training of teachers. And then, of course, ethics in medical practice helps you understand what is patient autonomy and empathy, and actually helping patients get their quality of life worked out. So I would say that you do need a self-development plan, again, so that as a leader, you're able to empower people, you're able to inspire people, you're able to share a vision, and you're able to lead change. So it is very important that you do get help in getting all these things. And one of the things that we learned was the 5 practices of leadership, which I will use as I go along, telling you about the setup of the KNH palliative care unit. So this is how I will set it out. I will identify my point of origin, and then charting my course. I will talk about the reflections and upgrading of my goals. So of course you will have one vision, but as you go along the way and you borrow ideas, because you have your original ideas, but it is very good to borrow those other ideas that you find along the way. So you will update your goals, and then of course eventually become a guide for others, because in true leadership, you must create leaders, because you will actually find that there will be others who will make even better leaders than you. And depending on how it comes out, they might make you shine or they might outshine you. But I find that you do actually, when you get very good other leaders, they make you look better than you actually are. So that there are many things that happened in the palliative care unit in KNH, which I had very little knowledge about, but I had other leaders who worked within my departments who moved the unit ahead. And of course, retiring from government service and reinventing myself. Also, it's not called retiring, it's called reinventing oneself. So my point of origin, I was born in a family of 4. I was the second born. My mother was a nurse, and so she really pushed that one of her children must go into the medical world, and it ended up being me. I went to the University of Nairobi Medical School, graduated, and got a job at the Kenyatta National Hospital, Accident and Emergency Department. Now, when I worked in that department, you get to talk to patients so much, and I just felt that patients will tell you stories that have nothing to do with why they came to hospital. One of the things I remember is that every time it was time for children to go back to school, we'd get these ladies who don't want to go back to the countryside, which they would have to go when the children went back to boarding school, and they would present themselves in the accident and emergency department with all sorts of problems. And I remember just telling my colleagues, I need to get a job where I don't have to keep talking to patients. And that's how I landed in anesthesia. They told me, yeah, you can go to anesthesia. You will just be talking pre-operatively to the patient, and when you wake them up. And actually, that's what happened. I landed in anesthesia, which was something I liked, because even when I was in the A&E department, I liked dealing with the patients in who are semi-conscious, who we then needed to work out what was the problem. However, all this changed when my father got cancer. And I got to look at how doctors communicated with patients. And I was actually shocked that our communication was really bad. And I, for one, was very disconnected. I used to make patients sleep. I just wanted to know whether they were fit for anesthesia. I didn't care what they knew, what had they been told by their doctors, what did they expect, I put them to sleep, I woke them up and I walked away. And I then learned that even my communication was very poor. And my mother may have pushed me into medicine. My father pushed me into palliative care when he was diagnosed with cancer. When he was diagnosed with cancer, I brought him to KNH. I still remember I sent him to the doctor, but I did not go with him. I went back to work. He was done all his tests. He was given his tests, and he was told to go home with them. I'm not quite sure what they wanted him to do with them. The problem was that he brought them to me. And when he brought them to me and I read that he has cancer, I was so shocked. And of course, there I was, I needed to break the news to him. I needed to break the news to the other family members, but I was not prepared. And there was really no support for me as I did that. Eventually, I figured we needed to go to a surgeon because he'd had x-rays and we needed to get a biopsy done. We did all that and then went to the surgeon. And I still remember to this day where I was standing, what I was doing when the surgeon told me, there's nothing we can do for this patient, just take him home to die. Again, he didn't ask me who the patient was. He didn't know it was my father. He did not prepare me at all. And that statement, there's nothing we can do. That's something I would really like to get out of the system because it is so devastating. And you see, what was my father's problem? He couldn't eat. He was in pain, you know, but they were not doing anything about that. They were telling me, you know what to do about vomiting. But actually, I didn't know what to do. So I was very traumatized as I dealt with my colleagues. Eventually, I was told to take him to, eventually somebody figured and told me he can actually have some radiotherapy. And he can also have, I can also take him to the hospice, which is what I did. I struggled with my father for about 4 years. And by the time he died, I was really determined to change things. I remember at the hospice, I met a great team, Nairobi Hospice. I met Dr. Ali. And of course, they challenged me to go back to KNH and change things. Because then, of course, they started telling me all these stories about patients who are coming to the Nairobi Hospice. And then, of course, I started complaining to my anesthetic colleagues because of the habits we all had. And I remember the head of department called me and told me, well, you seem so distressed. I suggest you talk to the hospital CEO. And I actually went and talked to the hospital CEO. And I was quite surprised that he also wanted change. He told me he wanted to change, to reduce the queues in the cancer center. He also thought there were many patients on that queue who didn't need to be there. And he also got a lot of people walking into his office. So he suggested that I needed an education. And the hospital was actually very good because I was released to work in the Nairobi Hospice 2 days a week. So 3 days I worked in KNH, 2 days I worked at the Nairobi Hospice. And that took about 2 years. When I was through with my training, I went back again to the CEO. And I had written a proposal by now on how to start the palliative care unit. So when you want to do such a thing, you have to clarify values by finding your voice and affirming shared ideas, and set the example by aligning actions with shared ideas. So I found there were many people who had ideas and we kind of needed to put them together. So there was the formation of a steering committee that had a multidisciplinary team. Now, when I was asked to form this team, I actually suggested to the CEO that since a lot of people did not understand what palliative care is, I might not get enough people on this committee. But then the CEO told me it is fine, I will chair the committee. And the first committee was all heads of department. So we had the head of department for psychology, nutrition, physiotherapy. So we kind of got every team member. And in the meeting, we then decided who are going to be in the steering committee. So each head of department was asked to bring somebody. And of course, we then also reduced the numbers so that we would have an effective committee. But the most important thing is that the hospital management was fully in support of starting a unit. And eventually, we got a unit that started operation in March 2007, and we had 1 doctor and 2 nurses. And I also remember that we put out an ad in the hospital asking who were the nurses that were going to be brought. And eventually the hospital decided who were the nurses. So it was me as the doctor, Anne Mwangi and Catherine us, the two nurses who started off, and these were all people who were experienced in working with the hospice movement. Now, we also got many lucky breaks because at that point, we needed data because, again, if you're going to be in leadership, if you're going to bring change, you want data to support whatever you want to do. So the anesthetic department had just done a study about post-operative pain management. And it was noticed that, so they studied everything, you know, the vital signs, the drugs that were given. But I still remember that whoever looked at this data writes at the conclusion that there is something very interesting, that all patients with inoperable cancer, their pain seems to go up. So that if their pain was 5 out of 10, by the time they were 72 hours postoperatively, most of their pain was 10 out of 10, the intensity. So that was something that whoever analyzed that data looked at, and that helped us really push in the agenda of pain management. And it offered a starting point to lobby for the pain and palliative care unit with my anesthetic and surgical colleagues. So I still remember the surgeons were the most supportive because this study had been done in the surgical wards. The other lucky break came when we had a reporter who came to Kehpca Hospital and wanted to talk about morphine. And I still remember this story that was in the Nation. When morphine became available in the palliative care unit, so the terminally ill get something to smile about. And this patient, who actually died a few weeks after this photo was taken, he had a tracheostomy. He was an ENT patient. It got a lot of coverage. And after this story came out, I remember I was called to the CEO's office. And that day when I went to the CEO's office, I just walked in. I was offered a cup of tea or coffee, which I found very interesting. I actually did not connect it with this article. But then when I sat down, the CEO told me he's gotten calls from all over. And so we really need to get palliative care going and morphine, you know, and everything. And it was another lucky break in that because this article was about, you know, it was patient-centered, it actually did do a lot of good into getting the palliative care unit going. And of course, morphine being available much more easily within the hospital. So in leadership, you have to have reflection. And as you get more ideas, you know, everything tends to grow. So self-reflection is very important. And this is a process of examining, linking, and developing meaning from the experiences you're getting. So you start off, you know, for me in the beginning, it was just communication. With time, it then became pain management. But with time, there were other experiences that made us know we needed to change other things. And reflection, it involves examining your current level of skills, your strengths, your weaknesses, your behavioral patterns, and how you seek to influence others. So as a leader, you must always take time to review yourself, and it is critical for your development. So with these reflections, what did we do? We inspired a shared vision, and we enlisted others in a common vision. So what happened is that I got other people walking into the department, also wanting to improve quality of life for a different population. So we had started with the adults, but now there was pediatric palliative care. Pediatric palliative care was very challenging. The pediatricians were not willing to allow palliative care into the pediatric wards. And actually, we had to look for a way to get in. And what we did was we got the parents to write a letter to the CEO. So they wrote this letter, which of course we helped them write. We got them to sign, and then we got them to ask for a meeting with the CEO. And they went and told the CEO why they felt that palliative care. So we had a meeting with them. They understood how palliative care was going to help them. And actually, again, it took the intervention of management to actually get pediatric palliative care going. The next one was the wound and stomach and incontinence. This also came from other leaders in this, in that practice, who were in my department wanting to move that agenda and get it to the next place. There was then education of hospital staff and the University of Nairobi Medical School and the KMTC. Later on, we got somebody else telling us how we could improve patients' quality of life by dealing with accommodation, navigation, and transport. And the other one that we never quite set up, but which also looked like something that really was the staff support and opioid addiction. From walking around the hospital, giving a lot of talks, we discovered we had a lot of addicts, not just to opioids, but to many other things. And that is actually something that has space that needs to be developed within palliative care, because people found it very easy. When we went to give talks in wards, people would point out the addicts to us and they would want us to help them out. But it needs, you need to develop a goal so that by the end of it all, you have actually helped the addicts. So how did we get the wound, stoma, and incontinence? We had 2 visiting German nurses. And when they told us they wanted to visit and they asked us whether we had a wound management advisory center, they actually told us that we told them we didn't have. So they told us they would like to come and show us feasible and budget-friendly ways of managing malignant wounds. We welcomed them. And then we wrote a letter to the whole hospital. And we asked people, if you have a malignant wound, can you tell us about it? And it was horrifying. There were so many wounds within the hospital, patients who were just in the hospital to get their wounds dressed. And what we learned was they could actually be at home as long as we had a place where they would be coming to get dressed and go back home. And so we got the idea of a nurse-led wound center, which is what they have now. So this was one of the first patients we saw. This child had this wound in the anterior chest, and this wound was dressed every day. We also met this lady, and her biggest problem, of course, was the maggots that were on her breast. And it was a really, the wounds that we saw were really horrifying, and we really worked hard to reduce this suffering that the patients were going through. So one of the other things that you need to do in leadership is you must enable others to act. So foster collaboration by building trust and facilitating relationships, strengthen others by increasing their self-determination and developing competencies. So we had others in my department who really had the determination to change things. And of course, what we discovered is that driving good ideas into practice is not easy, because good ideas are not adopted automatically. They must be driven into practice with courageous patience. So it took a long time to actually get the wound, stoma, and incontinence going. But as it is today, you never even know that it started in the palliative care unit, because once it was established, it was moved to the surgical unit. And now even the hospital does do a course, an education course in wound, stoma, and incontinence. So it has come a long way. So there was the making of a nurse-led stoma, wounds, and continence clinic. And Elizabeth English was one of the people who helped us from Australia. And you can see her in this picture, donating a trolley to wheel the stomach wounds and continence supplies around the hospital. So this was an effort that was between Aga Khan Hospital and Kenyatta Hospital. So the program actually of teaching, the nurses went to Aga Khan Hospital because KNH was not able to host the program. But we got our nurses trained, and eventually we got the wound clinic in place. So now the other partnership that came was with the American Cancer Society. And we still laugh today that when the Americans told us that we could get the patients to do better than they were doing, you know, as a group, we were not so sure that there was actually anything else. We really thought we had done a lot, but it is good to search for opportunities, experiments, and to take risks. So in 2015, we had the representatives of the American Cancer Society. They visited the hospital, and eventually they met the management, they met the clinical heads, and at the end, the programs they wanted to start were brought to the palliative care unit for us to continue discussing with them. And it was decided that we should do a study. Again, data really helps if you are to get a vision and to lead change. So we did this study, which was reducing barriers to cancer treatment completion. And basically what we wanted to understand was transportation, lodging, and treatment literacy resources. So we were asking about what they thought we needed to change. And this is what we found out, that almost 60% of patients had a problem with accommodation. Money for transport, they felt they were not healthy enough to continue treatment, and a place to stay. So this all kind of went into accommodation. But I think for me, the most shocking thing was when we realized what was their biggest challenge. And one of the biggest challenge was lack of water to drink, which I think 99% of the patients said that they used to be in these queues and they would get so thirsty. Of course, you ask yourself, why didn't they carry water? Why, you know, you ask yourself, but then I guess they didn't expect to be in that queue for so long. And I mean, that seemed like a small problem that we didn't need to wait to discover that that was a major problem. Actually, the hospital went into a lot of lengths to make sure that water was available. Because for the other things, like waiting for a long time, a lot of patients said they understood that there were so many patients. But then again, something can be done about that because people can be given appointments so that they come when it is nearer to the time they will be seen. So we learned a lot when we collected this data, and a lot of things that we did not expect. So we tried to correct a lot of those things. And again, the program now is with the Cancer Center, where there are navigators, where patient education material is available. Equipment was gotten to help with them physical navigations, so that if a patient has to go around and they cannot walk or they're feeling so sick, at least there's equipment. And of course, the hostel is something that we are still hoping to get built, although we've gone quite a long way. So now the other thing that must happen in leadership is you must encourage the heart. You must recognize contribution, and you must celebrate the values and the victories. So within our unit, we had a lot to celebrate. So we celebrated each other. We celebrated our victories. We encouraged each other to invest and to build oneself. We enjoyed traveling as a group, and we traveled every year out of Nairobi. And actually, just before I retired, we were to travel to Dubai, but COVID dealt a blow. And we celebrated each other because the richness of the team is the diversity of people, perspective, and disciplines. So we had nurses, physiotherapists, psychologists. So we had many people in our team, and we tried to encourage each other. So as I retire and reinvent myself, one of the things that I do not intend to give up is palliative care, because much as it was not what my career was about, that is one thing I find you can use anywhere. So I have now started a home. It's called the Alpine Pristine Homes, where we offer compassionate care. We started off with patients at end of life, but end of life is a very taxing thing to do. I think it needs a bigger institution. So now we look after patients with dementia, because they have a lot of health-related suffering. Because as you get dementia, you become like the younger person, where you will need diapers, you will need to be looked after in many ways. And a lot of these patients also have other medical conditions. So how do you make the impossible possible? To succeed, you need to be committed. You need to learn from your journey. You will not always get things right. You must learn from others. If you get to a place where you are not moving on, you need to ask yourself why, and look for what it is that's making you move on. You need to have fun along the way, and you need to think positively. So you must always, you will get negative thoughts, but try and look at the positive things about it and change your perspective. You must also be very honest with yourself, so that if there's something about your personality that gets into the way, and you have somebody who is able to tell you about it, then you should be honest with yourself and change that. You must try and take away distractions, and you must count on yourself. Keep planning and replanning if you need to. And you should avoid getting burnt out. Don't be obsessed. I know a lot of people think because I talk about palliative care, I am obsessed about it, but actually, no, I am not. When it's time to go home, I do go home and forget about it. So you should avoid getting burnt out, because that happens to a lot of people. And they have to totally change course. So how do I see the way forward for us? We need to develop interdisciplinary palliative leadership in these 5 limbs of administration, and the administrators will lead and manage programs. We also need to develop leadership in clinical practice, and this will promote, for those who will promote excellence and evidence-based practice. And of course, we need research so that we grow and mature the evidence we have for our clinical practice. And then education, so that we are assured that palliative care skill development for all healthcare professions as they enter into practice. And then, of course, policy and advocacy, and I'm very happy we've done so well with getting a policy. This will guide change in the healthcare delivery and access to palliative care. So for now, I think we need to integrate palliative care into the medical care, especially oncology, social work, and psychology. I think those are the areas that we could start with. We also need to talk to insurance so that we can get insurance cover for palliative care. We need to improve on our advanced directives. If we could get improvement in our advanced directives, we can bring the cost of medical care down. We need to improve pain management, end-of-life care. We need to develop inpatient hospices, and we need to have some regulation of home care agencies, because currently they are available, but we are not quite clear about exactly how they work. And I do think that this is something we could develop. So effective palliative leadership will promote a focus on quality, patient-centered care, and the change in policy that we are trying to effect. So what is the take-home message? So the take-home message is sorry. Oops. So the take-home message is that if you change nothing, nothing will change. No, sorry, I'm trying to read this. In order to be successful, palliative leaders must build a culture of shared leadership. So we need in our teams to have shared leadership where the ownership is widely distributed among the team and where everybody has the right responsibility and the ability to be a leader. So we must develop our team members so that they become leaders and all of us can make a difference. Thank you. So I will stop sharing. Okay.
Thank you so much, Dr. Munyoro, for such a lively and very inspiring session. I've learned a lot, and I'm seeing in the chat the participants are giving their key points, what they have learned, and I like it because they're looking at the positive side that at the end of it, we should celebrate and keep learning and celebrate each other. So I don't know if there are any questions. I have one question from Facebook Live, and they're asking that from the experience with pediatric palliative care, how comes the pediatricians seem to be against palliative care while the parents were receptive of it?
I think the problem is when you think about children, you know, children are not supposed to die, you know, and I think the way I found it is that the doctors were working so hard and they were finding it very hard to give up. So these were parents who used to come. In fact, there was a man called Nyaga who was very involved. He wanted to take his son home, but the oncologist was refusing. Now, of course, according to the law, the child has a right to good health. So obviously, if the father says, I want to take my son home, and the pediatrician says, no, your son still has something we can do, it looks like, you know, the pediatrician is right. But I remember like that boy, you know, he was dying. We all knew he was dying. But for some reason, the oncologist was finding it hard to accept. So I think you, first of all, have to accept death. So I think they also needed to kind of, in themselves, accept it. And then also look at the child from the child's perspective. There were children we interviewed who wanted to go and spend time with their brothers and sisters. They had been in KNH for 1 year. But of course, the oncologist was more worried about them missing their next dose or, you know, that kind of thing. So it's all about children's rights. It's about patient-centered care. It's about what the child wanted, you know, there were patients in the ward whose marriages were breaking because this mother came with the child to hospital and left her husband and her husband. There's one man I remember who took the other children, took them to her mother, and, you know, he just disappeared. So you see, the parents had other real life issues that were coming up. which they needed addressed, you know, and they got to the point where, like, that lady wanted us to transfer the child to Nyeri Hospital so that she could try and save her marriage. Now, of course, when I go to talk to the pediatrician and the oncologist about her marriage, you know, they would ask me, do I have a problem? I mean, most of them used to think we have the problem. But I think it was that, you know, that health-related suffering and identifying with those problems. I don't know whether that answers the question.
Thank you so much. Just for adding other comments, nice presentation. There were a lot of congratulatory messages, Dr. Munyoro. There's one from Elizabeth. This is one great presentation, proud of where you've been. And then there's one from Pamela. It works well when the system supports your vision. Leadership works well when the system supports your vision. There's a raised hand from Beatrice Akelo. Beatrice, do you have a question or a comment as I read the other comments? Yeah, the work is very inspirational, very great, thanks. Yeah, and then there's a question, okay, there's a comment by Mercy Kaleha who says that I have learned that management and leadership are two different things, as management is majorly doing things right, while leadership is influencing individuals. Leaders are always made, and as a leader, we should encourage the heart and recognize contributions. So the question I have is for you, Dr. Munyoro, are there instances where a leader is both a leader and a manager? And what happens in such instances? Where a leader maybe will take both the management and leadership roles?
Well, you can be a leader and a manager, but I would encourage you to give the management role to somebody else so that you are managing, because you see, managers have a lot of work to do. You have to see that things are done in a certain way. The thing is that even if you're managing, you as the leader, if you see things can be done differently, the thing is not to try and do them overnight. Because if you want the manager to get them right, you have to change your vision into a process and just get it really done how it needs to be done. And I'll give you an example. When we saw our vision, we wanted to change our vision so that now we deal with quality of life, let's say for the pediatric patients or for the stomach patients. We then had to go back to the beginning. You need people with an education. You need to have a proposal. You need to know how you're going to implement it. So you can be a leader and a manager if you have enough time. The problem is, like KNH, to get things done, you have to really lobby. And you lobby with data, you lobby by talking to, you know, if there's a committee of 10 that sits to give you an office, you have to make sure by the time that committee sits, 6 people are convinced. You see, even to get an office, we had to lobby the housing committee. And we had to explain to each person what is palliative care. So you have to do a presentation to that committee. So you can do both. The thing is, do you have the time? Do you have the, are you able to concentrate? Because the problem is, are you going to be able to do both of them? But what you can do is you can be the manager, but have somebody else getting the processes done. And that's what works. I mean, in most organizations, you decide that you want to go and give a talk somewhere. You will get somebody to do your slides, somebody to put the pictures in, you know, yeah. So you can do both. But it is like in our department, we had a very good manager, Anne Mwangi. I still say that a lot of what happened is because we had such a good manager. So you need your management also to be right so that whatever you come up with, then the manager can actually put it into action.
Okay, thank you so much. And it's already 8, so I'll just go through 1 or 2 questions. And I've seen the comments coming. I may not be able to read all of them, but thank you so much for the encouraging messages that are coming through. So if you allow me, I'll finish in the next 4 minutes by reading 1 more question. Linda Mungai, who asked the question about pediatrics, has said that her question has been answered and she's thankful. David is asking, do leaders thrive in all fields? Because there's a tendency of leaders being given many responsibilities in different aspects. for example, health, social, and spiritual cycles, of which they must identify what priority that they are able to build up. What is your wisdom on this?
Okay, thank you, David, for that question. Okay, so if you're the leader, you must, I think you need to look at your team. You must know how your team leaders are gifted so that it is not, okay, so if you came to our department, people were gifted in different things. Of course, when we did the presentation, it may look like it's Dr. Munyoro who is doing it, but the thing to do is that you must seek those who are gifted in the different areas in your department, because you can give leadership in all areas. The only thing is that it can be a lot of work, because if, let's say, it is spiritual, then you would need to get a lot of that. You'd need to learn a lot. But it is much easier if you get the person who seems to do well in that field to either educate you or to help you. So leadership is about building other leaders. So I think that's the way it should be, that you allow different leaders in your group to come up. And the thing is that you will get leaders who will totally outrun you. They will do so well that you will not even have known you are sitting with somebody who had such in them. And you can do it either way either. So when it comes to the end result, it could be either, of course, that now is the problem that I find with a lot of leaders, in that they do not allow those other leaders in their teams to shine. But actually, sometimes if you let them shine, they actually do you so much good. And the end result, of course, is that the whole team moves ahead. So I think the problem, it can be too much, but I think you can support the others in your team who have those qualities that you do not have.
Thank you so much. There's a comment from Beatrice Akelos saying good presentation and experience. And you're saying that the future plan is that even after retirement from the government, you are still continue to serve community. So that is you've encouraged some people. There are more questions coming, but time is running very fast. But allow me to read maybe the last two questions and then we'll close. If there are any more questions, I'll ask Dr. Munyoro maybe to put in our contact details. We can always continue with the conversation, and also Kehpca's contact details on the chat. So you can take it up and then we can continue. So the second last question is, there's a question from Tricia Ireri asking, what is the one ask palliative care enthusiasts in the civil society space need to pitch for?
Sorry, just say that again.
What is the one ask that palliative care enthusiasts in the civil society space need to pitch for?
What is the one ask? What is the current ask?
Yes, if you're to pitch for a palliative, what can we pitch for as the civil society dealing in palliative care? If you are to be given one as a chance to give one ask, what would you suggest we do, or the civil society community ask for?
Okay, I don't know. I think for me, it would be a selfish thing to answer, because currently I am obsessed with the Hope Hostel in KNH. So that is what I am. Anytime I get a minute to talk, a minute to remind people that our patients are still sleeping in the corridors. And what has happened is that with the COVID, even those relatives who used to accommodate people are not willing to accommodate. With COVID, sleeping, people used to come and hire a room in Kehpca. And, you could, 5 patients could get together and hire a room. That is a very bad idea in the COVID era. So what would I like? I'd like us to fundraise. We need 150 million. That's all we lack currently. We have everything. We have the land, we have all the licenses, we have architects, we have everything. We just need 150 million and we are good to go. But I will leave Kehpca. What would you ask? because I know you look at it nationally. I am only looking at it from my point of view. My point of view, guys, let's get the hostel built. It is so important to support those people. It is cold. They are still sleeping in the corridors of KNH. It really does me. So, Maculin, I think you can tell us what is the ask.
Okay, thank you. So before I go to the last question, as you said, everyone is all are leaders, and at Kehpca, my colleagues are all leaders in their own ways. So I'll ask one of my colleagues to answer that. At Kehpca, if you are to give that one ask, what will it be? David, Esther, Howard, Josephine, those are my colleagues. Miriam, anyone of us, anyone can give an answer on behalf of Kehpca. Then I'll go to the last question and we'll close.
I think for me, I'd say having palliative care as available as air. So palliative care for all who need it when they need it.
Yeah, thank you so much. Thank you so much, Esther. And as you mentioned, it really resonates with this year's World Hospice and Palliative Care Day, where we're talking about leaving no one behind. So as Kehpca, we are really looking at working on strategies with our partners on leaving no one behind, anyone who needs palliative care, despite their age and the condition. And we'll be working, going forward, we'll be working with all you as the partners. We're not going to leave any partner behind as well, who is able to support palliative care in one way or another. So thank you, Esther, for that feedback. So the last question, as we close, I think is a comment, maybe for Dr. Nyoro. Linda Munga is saying, I was thinking about the need for regulations on home care, especially because it's a sensitive area and it involves going to people's homes. So maybe you can give a comment on that, Dr. Nyoro, and I've seen you put email in the chat. So for any other further questions, please pick Dr. Nyoro's email and you can communicate further.
Well, I think, yes, I think Kehpca, in fact, I think needs to do that work. I think we need to regulate the home care agencies. Of course, you can't regulate something if you are not going to support them. So I think we will need to do research. We will need to find out what is needed. We will need to know where it falls. You know, does it fall under public health? Does it fall, you know? So I think, yes, there is need to regulate home care. I think it is the next big thing about palliative care. We actually do need to get there. But I think before we get in there, we need to, you know, just get our research done properly, because like they say in psychology, if something is working, you should not try to make it right unless you really know that if you bring it down, how you're going to make it right. So sometimes you can find people who are living together but have a bad relationship. You don't go there and start criticizing. You really don't know how you're gonna make it any better. So I think it's something we need to eventually move into, and you know, Kehpca as the umbrella body will eventually need to give us some guidance, so that there are many times you will find that there are people who don't give the right care at home, or you know, the charges, or you know, so there are many things that need to get corrected. Or some people give care to patients who could go to hospital and actually get something done that would reverse whatever it is. So there are many things about it, but I think that is work that still needs to be done, because you need to have the right information before you get into it.
Okay, thank you so much. And that marks the end of today's presentation. I'd like to thank my colleagues from Kehpca, the team behind making this session possible, and the participants for making time over dinner. You've sacrificed dinner with your family and making time for this session. I hope you have learned something, and it's going to be helpful in your work as palliative care experts, as current and future palliative care leaders. So I wish you a good evening, and We look forward to meeting you in the next session. Have a good day.
All right, thank you very much.
And thank you so much, Dr. Munyoro, for taking your time to provide this a very useful session. We've learned much from you. And I know we will get people following up with you on and learning more about your experience. Thank you so much for sharing your experience with us. We really appreciate it.
All right, thank you.
Thank you. So have a good day and good night. You're free to leave at any time.